My dear students, Dr. Ashfaq over here, and as you are well aware, I have authored books for NEET Pg, NEET DM, NEET MCH, as well as some of the books for USMLE examinations, MRCP examinations, and my lectures would be intended to get you right on the top there for your next examinations, DM examinations, MCH examinations, MRCS, MRCP, USMLE examinations. I hope my videos will benefit you a lot. I will be presenting my things in a very easy, simple and palatable form for you. Wish you good luck for your exams. Thanks a lot. My dear students, today we will be taking up a very important intra-abdominal organ, and that is the kidneys. As far as the kidneys are concerned, we will be dealing with the multiple aspects of kidneys, the surgical anatomy, the exposure of the kidney, the applied aspects, the medical and some of the common surgical conditions associated with the kidneys. First of all, as far as the anatomy of the kidneys is concerned, you have to remember that the kidneys, we usually refer the word nephro or renal, pertaining to something bean-shaped. So bean-shaped organs, also referred in medical terminology as nephro and renal. And this is an organ which lies applied to the posterior abdominal wall, and that's important as well. The kidneys in fact occupy the abdominal areas. They occupy the right hypochondric, the right lumbar, and the left hypochondric and the left lumbar, in addition to the umbilical and the epigastric areas. So these are the four quadrants which the kidneys occupy: the epigastric, umbilical, the lumbar and the hypochondric areas, the right and the left, as far as the right and left kidneys are concerned. In addition, you have to remember that the normally kidneys lie within the T12 to L3 vertebra. So you have the 12th thoracic vertebra and you have the 3rd lumbar vertebra. The kidneys vertically lie in this plane. And as far as the kidneys are concerned, you have to remember that roughly the kidneys are 10 to 12 centimeters in length, and the thickness is just almost 2.5 to 3 centimeter, and the breadth ranges from 5 to 7 centimeter. So these normal parameters you have to remember, because in certain cases the kidney size, especially for an ultrasound person doing ultrasound of the kidney size is important in case of certain diseases. That's one important thing you have to remember. So the dimensions you have to remember. And as far as the kidneys are concerned, they do not lie vertical. They lie just like this. The upper poles of the kidney are nearer to the midline and the lower poles are a bit farther. So that's important. As far as the kidneys are concerned, they have got two poles, the upper pole, the lower pole, the two surface, the anterior surface, and the one which will lie posterior, the posterior surface, and two borders, the medial border and the lateral border. And there is something important at the hilum. At the hilum, we have got this, we can identify the right or the left kidney as far as relations at the hilum are concerned. So the renal vein, the renal artery, and the renal pelvis from before backwards. The renal vein comes first, the renal artery comes second, and the renal pelvis comes third, and then you have the ureter which continues downwards from the kidney. So this is important as far as the kidney, its dimensions, as far as its relation at the hilum are concerned. Now, kidney is very important anatomico-surgically, because we have got many organs which form the relations anteriorly to the right kidney and the left kidney. So we have a surgeon can operate the kidney from front or back. The backward approach is preferred by many, but you have to remember the structures which lie on the anterior surface of the kidney. So as far as the kidney is concerned, we have got the suprarenal or the adrenal. Suprarenal lying at the upper pole of the right as well as the left kidney. So this, on the right kidney, we will take right kidney first. We have an area for the suprarenal gland, and then this is a big area for the liver, the right lobe of the liver, the hepatic area. Then we have the colic area over here, the jejunal area over here, and near the hilum we have got the duodenal area. So this is one important thing. So you can see the vein coming anteriorly over here, and this is the left kidney, this is the right renal vein, and this is the left renal vein, and you can see that both drain into the inferior vena cava, and the left renal vein is a bit longer than the right renal vein. So that's one important surgical concentration. Now, as far as the left kidney is concerned, again, as previously demonstrated, this is the suprarenal area at the upper pole of the left kidney, and this is the area for the stomach, the gastric area. Then over here, more laterally to the left, is the splenic area. Over here we have the pancreatic area, and again the colic area here as well as here, okay, and then the jejunal area over here, okay. This is the ureter from the left side, and this is the ureter from the right side. So these are some of the important anterior relations you have to remember, because this is a question sometimes asked, diagrammatic representation showing the anterior relations of the kidney. Now what's more important is posteriorly. For a surgeon who operates the kidney from the back, you have to remember some important structures which lie posterior to the kidney. So over here you can be having the diaphragm, the right diaphragm, the right hemidiaphragm on the right kidney, and the left hemidiaphragm on the left kidney over here, from the area over here. And then this is the lateral arcuate ligament and the medial arcuate ligament. So you have the medial arcuate ligament medially, and this is the lateral arcuate ligament laterally. These form important postulations of the kidney. Then you have three important nerves: the subcostal nerve, the iliohypogastric, and the ilioinguinal nerve. The subcostal, iliohypogastric, and the ilioinguinal nerves are very important as far as the postulations are concerned. In fact, the subcostal nerve is accompanied by the subcostal vessels as well. That's important. And you have three important muscles. From medial to lateral, we have got the psoas major, a very important muscle, quadratus lumborum, and transverse abdominis. So psoas major medially, and this is the quadratus lumborum in the middle, and the transverse abdominis laterally. So this is some important point about the posterior relations of the kidney, and this is sometimes frequently asked as well. Now, as far as the kidney is concerned, you can see once we have a section at the level of the kidneys, this is the kidney, and the kidney has got a capsule, which is a peripheral condensation of the gland itself, the true capsule I mean to say, and this is the capsule of the kidney, the renal capsule. And over here, next to the capsule is the perirenal pad of fat. So this is the perirenal pad of fat, and you can see over here, just outside the perirenal pad of fat is the pararenal pad of fat. This is very important. The pararenal pad of fat which lies outside to the perirenal pad of fat. Now, as far as the kidney is concerned, you have to remember that the kidney is enclosed with the fascia, and the fascia covering the kidney has got two layers. The anterior layer, which comes anteriorly, is given the name as fascia of Tolt, and the posterior layer is given the name as fascia of Zucker-Kendall. So fascia of Tolt is the anterior layer of renal fascia, and the posterior layer is the fascia of Zucker-Kendall, and it comes posteriorly. They just go upwards and just enclose the suprarenal, and again open up just below the diaphragm on the both sides. So that's something bit about, which is sometimes asked, what do you mean by fascia of Tolt and what is fascia of Zucker-Kendall. So that's very important. Now, in addition, there is something, once the surgeon approaches the kidney posteriorly, what he encounters three layers of the thoracolumbar fascia. One is the, first of all, posterior layer of the thoracolumbar fascia, which you can well appreciate over here. Then there is the middle layer of thoracolumbar fascia over here, and then there will be the anterior layer of thoracolumbar fascia, which is present here. So anterior layer of thoracolumbar fascia, the middle layer of thoracolumbar fascia, and the posterior layer of thoracolumbar fascia. Okay, this one. Now, there are some muscles which you can just encounter while you just go from behind, from the posterior to the anterior aspect. So you have got over here this muscle. This is the latissimus dorsi, and this is the serratus posterior inferior. In here again you have the quadratus lumborum, and over here you have the psoas major more immediately, and this is the kidney. So once you approach the kidney from here, you have to go through the posterior layer of the thoracolumbar fascia and the middle layer of thoracolumbar fascia, and then you approach the kidney with the pararenal pad of fat over here, the perirenal pad of fat, and the capsule of the kidney in there. So again, a cross section which well demonstrates the perirenal pad of fat over here, the kidney in here. This is the renal pad, perirenal pad of fat, and outside is this the pararenal. So this is the perirenal pad of fat, this is the pararenal pad of fat. This is the anterior renal fascia, the fascia of Tolt. And over here, this is the posterior renal fascia, the facial Zucker candle, and that's important. And this is the general peritoneal cavity, and this will be the aorta, and this will be the inferior vena cava. This will be the renal vasculature exiting from the renal hilum. Again, the vascular supply, the renal artery over here, a branch of the abdominal aorta, just supplying the kidneys over here, and then they just divide into segmental, subsegmental branches. The veins also follow the same pattern. They also arise from subsegmental and segmental branches and eventually drain into the inferior vena cava. Why I mentioned this slide over here is that this pattern of vasculature is common and normal, but it is subject to a lot of variation. We have a lot of anomalous variations in the renal vasculature. You can have axillary renal vessels, and that's important as far as transplant of the kidneys is concerned. There you have to be very particular about doing the renal angiogram first in the donor as well as the recipient, so as to have a perfect match of the vascular supply of the kidneys. Now, why are kidneys important over here? The first thing you have to remember is that this slide, a bit not clear, but you can appreciate that this is the kidney and this is another kidney, and this kidney is having a lot of cysts over here, and this clinical condition is given the name as polycystic kidney. Polycystic kidney is one important condition in which you have got the kidney parenchyma replaced by cysts. That is, there is a loss of functional performing renal tissue, and this can lead to eventual chronic renal failure. Now, there are two variants: the adult polycystic kidney disease and the childhood polycystic kidney disease. You will be dealing with the pathological aspects of these in pathology and surgery and medicine, but over here you have to well appreciate that we can have the presence of multiple cysts in the kidney, a condition given the name as polycystic kidney disease. So this is one important fact you have to remember about the kidney. As far as the kidney is concerned, like the gallbladder, you can have the presence of calculi, and these are the calculi which can present in the pelvis of the kidney, and some can droop down into the ureter, the ureteric stones. Okay, so these kidney happens to be a very important site for stone formation, a condition called as nephrolithiasis. So nephrolithiasis is one important clinical condition in which you can have the presence of stones within the pelvis of the kidney. Now, anatomically, a question sometimes asked, what is Morrison's parallelogram? How do you ascertain the position of the kidney? The fact is that we can just have the kidneys lie between the level of T11 and L3, and what we can do from the midline, we just draw a perpendicular plane to the horizontal planes as mentioned, along the T11 and L3, and this one perpendicular line at a distance of almost 3.75 centimeters from the midline, and the lateral one at a distance of 8.75 centimeters from the midline. And this is the area while you have approximately 90 to 95% chances of locating the kidney if it is normally placed. So this is given the name as Morrison's parallelogram, and the chances for a surgeon to locate the kidney on the right as well as the left side is high if he draws a Morrison's parallelogram. Why? Because sometimes there can be a kidney which is displaced or which is ascended kidney. Okay, so there is one important thing, that the kidney normally should be present at this place. So this is how you draw a Morrison's parallelogram. Now, as far as kidney is concerned, kidney is a common site for cancers, and you can have many types of cancers in adults, different types, and in children and neonates, different types. So renal cancer, renal cell carcinoma happens to affect the kidneys, and renal cell cancer can be of multiple subtypes. The most common, the clear cell carcinomas. In case of children, the Wilms tumor, and many other varieties which you will be dealing in pathology. So this is something which you have to remember about the kidneys. Now, in addition, we stop over here oh, is this all about kidneys? No, sometimes because kidney is an intra-abdominal organ and abdomen is subject to trauma, many a times we can be having lacerations of the kidney, you can be having subcapsular hematomas or collection of blood within the kidneys which can just get infected later on and cause an abscess within the substance of the kidney, a renal abscess, or outside the kidney, perinephric abscess. That's important. So in trauma, kidney has to be taken care of, and you have to appreciate once there's an abdominal trauma or polytrauma, the kidneys should be evaluated well. In addition, sometimes we can have a clinical entity as far as the embryological failure is concerned, that the two kidneys fuse along the posterior poles mostly, and that clinical condition is given the name is horseshoe kidney. So horseshoe kidney is one clinical entity. You have to remember, very common in Turner syndrome patients, but you have the kidney just fusing, the posterior poles fusing, and that clinical condition is called as horseshoe kidney, and you have to differentiate it from one thing, which is the pancake kidney, when there is a mass of kidneys, lobulated mass of kidneys present on one side. That's given the name as pancake kidney. So pancake kidney is one clinical entity you have to remember. In addition, sometimes we have got a condition called as floating kidney, in which the kidney is not present at its normal position, or there can be ptosis of the kidney. Visceroptosis, was the viscera are displaced from the normal position. That clinical condition is given the name as visceroptosis, and nephroptosis or renal ptosis is the name given to a displaced kidney. And floating kidney is one kidney in which there is a laxity of the fascia covering the kidneys, or there is loss of the fat covering the kidneys, as a result of which a kidney can be displaced from its normal position. So these are some of the very important anatomical and surgical conditions related to the kidney, and I hope that these points will help you well in your preparation for your examinations. Thanks a lot.